our presenter today in just a moment, and then I'm going to go into the background of Nick very briefly. I think most people have been here before, and then Ryan Howes, our presenter, will go into his presentation, again, hopefully with some give and take throughout the presentation. And then at the very end, we will talk about some the upcoming webinars, as well as an upcoming event, a conference that we want to tell you about that Kate Ryan with our partner Iris Solutions is going to tell you about. That'll come later on. Next, please. So the National Interoperability Collaborative, again, most of you know this already. It's a community network. These Friday calls are just one piece of what we do. It's a very active piece of what we do. One of the people on this call, Dave Walsh, actually a couple of people on this call, had a proof of concept project that the group is doing. So we're active in, and we're also, and Nick is also active on the ground at various locations. So we do lots of stuff, and the hallmark of it is we cross domains. And that's really a hallmark of the work that a lot of you do, including Ryan's. And you'll hear more about that today. We focus on what we call domain sectors. People call them different things. And what we're evolving into is that you've heard of the social determinants of health and well-being. These are the 6 domains of health and well-being. They're meant to be umbrellas under which other domain sectors fall, mental health, lots of other things. But these are the principal ones in which we are working. Next. Yes, Nick is an idea whose time has come. I said last week, I'll say it again. It's not just the time has come, we're actually doing it, which is great. And so please do go, if you're new, please do go on, please sign up. And here, so I'm gonna turn it over to Ryan in just a moment. I'm not gonna read you his bio. I will say that we've done several webinars with organizations, with people who are doing real cross-domain work. Da Vinci, many others. I don't need to go into them. And we're trying to bring people in who are doing the work as we are to get people involved in cross-domain work. In particular, I think the Karen Alliance is interesting because they're very focused on what we all want to do, which is make this work very patient, client, person-centric. And that's what this work is really all about. And I'll leave it to Ryan to give you the details. Next. And I think Ryan, I think with that, I hand you the baton.
Hey, thanks, Adam. Thanks, Dave. And us as well. We appreciate the opportunity. And you're doing great work. The more that we continue to be involved in it, the more we realize that we are touching pieces of an elephant. And so the more pieces we can touch, the better. And I think for the first time, as you mentioned, there's a lot of industry-led groups out there that are doing some amazing work, like you guys and others, to try to aggregate healthcare in such a way that we can point them in the right direction and work collaboratively together on where this goes. So just so you get a sense of my background, I've been 25 plus years in healthcare technology, mainly on the health plan and the vendor and consulting sides of the house, but have done work in Medicare, Medicaid, and commercial, including standing up some ACA exchanges in the past. So very recognize and understand the challenges states have as they try to stand up healthcare technology and what that actually looks like. And so our work here in the Karen Alliance is what I'm going to be focused on today. We at Levitt Partners, just so you know why we are part of this effort. As a business line, we took a lot of the principles that our founder, former Secretary Mike Levitt, created in a book called Finding Allies and Building Alliances, where we took those principles and said, you know what, there's a lot of things we can agree to in healthcare. And there's obviously a lot of things that we still have not agreed to, but of the things we can agree to in a bipartisan, industry-supported, person-supported way, what are those things that we could advance at scale in the industry? And so we use alliances to try to solve those difficult issues in healthcare. And we do about 30 of these a year, roughly. meaning not new ones. We run about 30 of them a year. And as a result of that, one of them is this group called the Karen Alliance, which we'll talk about today. Another one focuses on social determinants, and hopefully we'll have a little bit of chance to be able to talk about that as well. So, Adam, any preliminary questions there? Or,
Yeah, I actually do want to break in for a second. Let me put my video back on. With apologies, again, those of you who have been here before know that Daniel Stein, who's the head of Stewards of Change, and Nick usually runs these, and I do when he is away, and he's away on vacation. So I apologize. I did miss something at the start, so I'm going to interrupt you, Ryan, for just a few minutes. What we generally do at the beginning is let people who are new to these calls introduce themselves. Very briefly, a sentence or two, who you are, who you're with, and why you're here. And the way we do it is in the chat box. If you are new, just please type your name. I will call on you, make sure you're unmuted. I will call on each name in the chat box, and you will introduce yourselves. And then, so again, with apologies for the interruption, then we'll jump right back to Ryan. So please type your name if you're new. Anyone? All experienced hands? Well, if that's the case, going once, going twice. Aha. Aha. Julie Moss, please say hello to the group. Oh, without a mic. Okay, so I'm going to introduce Julie because she is on the computer without a mic. Not on audio yet, but hello. Julie says hello. Julie is with EMR Direct, which I do not know. If anyone does, please feel free to speak up. But Julie, we are very happy to have you here. Anyone else? Oh, Julie works in health IT on interoperability services and identity. Great. Next, we go to Crystal Sham. Crystal, please say hello. Unmute. Hello.
Crystal should be unmuted now.
Crystal, give it another.
Can you hear me?
There you are.
Hi.
Yeah, please say hello. Identify yourself.
Hi, my name is Crystal Schramm, and I work for the Michigan Health Information Network, or MyHEN, and I'm a product specialist. I just joined there this week.
Oh, great, great. Everyone welcomes you.
Thank you.
Serafina Versace, if I pronounced that correctly. Serafina, do you want to say hello to the group? Or I can
Am I on
yeah,
mute?
you are with us. Go.
Oh, wonderful. Thank you very much. I just am listening into your conversation today. I have been a long time independent contractor in HL7 interoperability and have been following many of these programs. And so I'm just delighted to listen in.
Great. Welcome. And again, to all of you who are new, please feel free to join us on the in the NIC group and on a hub group if you are so inclined. And anybody else who's new, please type in your name. We have, oh, hi, Dawn. Dawn Bonder. Dawn, say hello.
Hello. I haven't joined one of these calls. I haven't had the opportunity in the last couple of weeks, but so glad I'm available today and very much looking forward to hearing Ryan's presentation. Nice to talk with you, Adam, as well. Hi, everybody.
Yeah. And Dawn is with Cedar Bridge Group, a wonderful organization we've done a good bit of work with.
Thanks, Adam.
Anybody else? All right. All right, terrific. Thank you. And again, welcome to everyone, new and old. With that, and apologies for the interruption, Ryan, please take it away.
Sure. Good to see everybody, and good to see old friends there too in the webinar that have really helped us advance these topics. So let's go to the next slide. I didn't know where kind of everyone's background was, so a lot of this may be review for folks. But we can definitely get into the details, and as Adam mentioned, and at any point if you want to stop, let us know. So historically in healthcare, we have had what I affectionately call the HIPAA box. We know how to exchange data there. We exchange it between covered entities and business associates. There are rules, privacy and security rules associated with those. And we, at scale in healthcare, are trying to make that happen better, especially for individual providers and health plans. We obviously in the Caring Alliance support that, but that is not where our focus is. Our focus is exclusively on finding ways for an individual patient, consumer, individual. I'm going to use the word consumer likely, and not that there's any magic to the word. We could use any of those words, but that's just the word that we have, where we are allowing for that consumer to actually aggregate all of their health information from all their providers, all the health plans that they've had, to an app of their choice in a secure and trustworthy way. This is that is our primary focus, is business to consumer data exchange, and that right now, that data is actually governed by the Federal Trade Commission under what's called Section 5A, where it talks about doing no harm to the consumer. The challenge with that is that basically the FTC guidance around that says that we're going to hold apps accountable based on their own individual privacy terms and conditions, the policies associated with that. And that is a concern, because one app may say, I'll never share your data without your permission, and another app may say, I will always share your data regardless of whether I have your permission or not. And so while the FTC can enforce individual privacy terms and conditions for app level based on what they've defined, we need to do something a little bit more broad to make sure that consumers have the same privacy and security alignment within HIPAA as well as outside of HIPAA. And that's where we've primarily been focused on. So we'll go to the next slide. So our vision, rapidly advance the ability for consumers and their authorized caregivers to easily get, use, and share their digital health information when, where, and how they want to achieve their goals. This is a small sampling of the folks we have involved in the Caring Alliance. You can see a full list of our participants on our website. If you can read that mice type there at the bottom, but you can go to caringalliance.com and you can find out a lot of the folks that are involved. But just very briefly, we have a number of patient and consumer advocates as part of it, a number of consumer-facing applications. We have all the major consumer platform companies besides Amazon part of what we're doing right now. We have 7 of the 10 largest health plans. We have a number of different health systems that are belonging to this, a number of pharma companies and PBMs. It's a very, very diverse group. And all the EHR vendors, either directly or through their associations, so, or at least the major ones. And so I would say it's very diverse. There's obviously a lot of opinions in the group that we have. And we have specifically, again, carved out this lane of getting patients access to their data and consumers access to their data. That has been our primary focus for the last about, since we've been in existence, 4.5 years. Next slide. So the first thing we realized that we needed to do, as I mentioned at the outset, is that we didn't want the data that would be sent from HIPAA outside of HIPAA to, I should say, to entities that are currently not covered by HIPAA, to just be governed by their own terms and conditions. Obviously, for anyone that's been in healthcare for more than about 3 seconds, that is not something that is sustainable. And so what we tried to do is to say, you know, we need to come together as an industry and as individual consumer and caregiver advocates and say, how do we protect the data in a way that really at least from a principal basis, meets or exceeds the same level of data security and privacy protections that they currently enjoy today within HIPAA. So that there's really no difference to the end user. And quite frankly, the end user will actually feel more empowered on how they're using the data going forward than they even do today within HIPAA. So we developed what we call the Karen Code of Conduct. We released it to the public for public comment back in November of 2018, and then we released a first version and got a bunch of public comments from that, and then released it officially as a first version in May of last year. The value for the Code of Conduct is it does a number of things. Number one, we want it to become the de facto standard for how entities that are not covered by HIPAA should protect the data. And if we do that as an industry, then a number of things can happen. One is we can have FTC enforcement of the code. Two, we can have private sector enforcement of the code, again, on a volunteer basis. And three is we can actually raise the bar in terms of privacy and security of the data, even though it's outside of HIPAA. And what I mean by that is, in the code, for those who would like to read it, there are smatterings of HIPAA in there. There's smatterings of GDPR and CCPA from California and other areas where we have basically said we're going to empower the consumer with the leading edge privacy and security ideas that are in the marketplace today. That includes informed, individual, proactive consent of where they want their data shared and with who. It also includes, for example, restricting downstream access to that data, binding the individual app that's aggregating that data on behalf of the consumer to ensure that they bind any other third party to the same individual consent requirements that they are obligated to follow as part of the code. And it does other things as well in protecting that information. That's kind of the foundational first step. We're working with data holders right now to get that in place across the country. The Department of Veteran Affairs has actually already implemented that as being part of their app registration process, and we fully expect there's other EHR vendors that are doing the same thing as we speak, as well as others that are going to make that happen at scale. We then want to move into other phases of this trust framework. We want to make sure that there is a consolidated set of questions for how these apps are, an agreed upon set of questions for how these apps are using the data itself, to then be able to ensure that the consumer has a common way by which they're actually looking at the information wherever they may choose an app, whether that's in Google or Apple, or whether that's in some EHR app store or health plan app store, that they have a common way to say, look, I only want apps that never share my data, never show me ads. It's always under control. It never leaves my control. All the way through the continuum of, I don't care who has access to my data. I'll post it on every social media platform available because I have a chronic condition. I'm at the end of life and I need help to try to find some type of clinical trial to be involved in, and anybody that can help me is helpful. I mean, we have patient advocates across that continuum, and we want to make sure that their individual preferences are met through this process. And then the final phase is that we anticipate that there will be certifiers that will come behind the scenes. There's a whole bunch of them today, UL and Drummond and ENAC and a whole bunch of folks direct. There's a number of folks that are out there that would validate these apps, that would say, not only are they self-attesting to the code of conduct, but we've actually looked at the code. We've looked at the app itself, and we can tell you that they are meeting these obligations, and they can put essentially a seal of approval on the fact that they are meeting that need. So we do see this as a phased implementation process. We're still real early in this game. By any stretch, as you look at the different places where these apps through the FHIR APIs are aggregating the data, we're only talking probably at most about 60 apps at most that are actually have access through the FHIR APIs and have become registered with these from our best guess. And so we're still super early. It's not the 500,000 that are in the app stores today. It's a very, very low number, but we have to make sure as an industry we can protect and secure this data and ensure that data sharing is only driven off of individual consumer consent, and that's what we're trying to accomplish. Let's go to the next slide. So key principles, I think I mentioned these at the outset, but just very briefly, we want to ensure that we fully inform the consumer to make an intentional decision for the best ways to direct their health information. This is not a legal privacy terms and conditions check the box choice. That's not what we're talking about. What we're talking about is much more on the Apple or Google side about saying, this application wants to share your data with XYZ application. Are you okay with that? And we're going to try to make this as intuitive as we possibly can. And what we're advocating for is a well-informed consumer means someone who can, read this at a, at a 5th grade level, for example, because we want this to be as easy and as simple as possible for consumers to digest. App attestation, we think that the apps are going to attest to and be held accountable for a set of structured and reportable responses on how they use that data. So how they make money is very important, where they use that information, how they use that information. Obviously, the model privacy notice that ONC has produced has really helped a lot of that. We're going to hopefully add to that with the work that we're doing as well, and enhance and improve that as we go forward based on the latest information we're seeing for industry best practices. And then finally, the consumer should have that ability to specify the exact purpose in which that data should be used. So we want them to be able to designate specific purposes. And that doesn't mean I want to share every single piece of data that has ever been found on me and received by me, for example, with everyone. It means that we're going to specify individual purposes for individual pieces of data. There may be situations where an individual app, and there's a lot of situations like this, where an individual app doesn't need every single piece of historical information on me. It may only need my age or my birthday or my last prescription. Those are things that we want to specify to be very specific in how that takes place. Next slide. So there are these rules that are out there that I think most folks are, at least in the health IT industry, are very well aware of. So I'm not going to spend a lot of time on this. There's more than 1,000 pages of proposed rules, both from CMS and ONC. But I want to touch on just some highlights here, but we'll go quickly on this, assuming that most folks are aware of these already. One is the interoperability and patient access proposed rule that came out from CMS. CMS oversees health plans as the regulatory body that oversees that, and they are requiring that these Medicare Advantage, Medicaid fee-for-service, Medicaid managed care, and QHP, qualified health plans in the federal marketplace, offer consumer access to plan and claims information through standard-based FHIR APIs. FHIR, Fast Healthcare Interoperability Resources, is a RESTful API standard that HL7 owns and maintains, and it allows for individuals then to gain access to that information. And there is, for the first time ever, the health plans, these health plans I just mentioned, are going to be required, at least in the proposed rule, if we assume that goes final in the manner in which they are proposing it, that they need to actually now supply that information to the consumer. So this is claims information. Think about it as explanation of benefits. Status of the copay, negotiated payment rates, et cetera, a summary of the claim in that FHIR EOB process. Also general plan information, including provider directory and adjudication information. Right now, there is, at least in the proposed rule, it did not indicate a specific standard by which to use, but we're going to talk about that a little bit here later on, about how we're going to be helping the industry, how we have helped the industry on creating a standard so that each health plan doesn't run off and create their own to allow patients access to their data. We'll go to the next slide. This is a fun CMS chart that talks about the proposed rule itself. Again, I won't spend a lot of time on this, but other than to say in the proposed rule, the implementation date was January 1st of 2020. That obviously will change now that we're past the implementation date and the final rule isn't out. I'm making an assumption there, but I'm assuming that's the case. We don't know obviously when that's going to be, but the idea here is within the next few years, there is going to be a finalized date by which these health plans that I just mentioned will need to provide patient access to their to their claims information through these APIs, as well as directory information and others. The other thing I would mention is that there is a requirement in the proposed rule for payers to participate in a trust network for health information exchange. That's somewhat of a new concept to the health plan industry of what that looks like, but there are trust networks on the provider side like Carry Quality and Commonwealth and Direct and other things that are there. And so this is an opportunity for health plans as well as providers to engage in a similar trust network so that the data that's exchanged either within HIPAA or to entities that are not covered by HIPAA, they can actually agree on the same set of data exchange principles for how that data should be shared. And so that's a good development in terms of how we create a national interoperability standard, a policy for everyone to follow kind of those same types of guidelines. All right, next slide. By the way, we can take questions at any time.
Ryan, this
Yes.
is Dave. Do you mind if I ask a quick question at this point?
Please.
You talked a little bit about claims data, EOBs. I would assume possibly eligibility. So there are standards, HIPAA standards, transactions and code sets. Where are you looking at supporting those, blending those, replacing those? Because I could certainly see where a consumer would want to use something equivalent to a 270, 271 to say, am I covered for this procedure and so forth? Are you looking at blending those or replacing those, or what are you looking at there?
Well, so I'm going to talk about that in just a sec, Dave, but I would say that we're not necessarily looking to replace those. As you know, HIPAA requires the EDI transaction sets to be in place for all health plans. That's what it is right now as far as what's required. But as far in terms of patient access is concerned, there is no requirement per se about how that data should be shared with patients. And so what we're trying to do is develop a FHIR-based API for individual members of the health plan to access their data on an app of their choice using these FHIR APIs. That's the kind of the goal. And so we're taking the best of the 835, 837 type transactions, putting them in a FHIR-based API so that the consumers then can gain access to it. And so we'll talk about how we're doing that just a second here.
That's great. Thanks.
Can I ask a follow-up question? This is Rita. Hi, Ryan.
Hey, Rita.
So does the individual have to be tied to a health plan for this to work?
That's a complicated question. So the quick answer is yes. So the answer is yes, because that's the way we authenticate the users today. And so an individual will come in, they will authenticate using the portal, they will then gain access to the data through an API. Now, in the proposed rules, there's also this ability for consumer to say, I need a 5-year look back on my information from all of the health plans that I've had in the last 5 years. Again, if that language goes final in that way, there needs to be a way to look back across the health plans I've had over the last 5 years and bring that data in as well. That's more of a Da Vinci use case that is being done right now. And so how those two things kind of bring together is a little bit more of a work in progress.
So based on what you're saying, if somebody is uninsured, but they've previously had like Cigna or Humana or some other plan, that they could still access their data through the other plan relationships, or?
Correct. That is correct. The key thing is they'd have to know their username and password for their member portal. That's the biggest hurdle. right now, because that's the way that we do smart on fire authentication today.
This is a very small point, but if someone leaves a health plan, do they get to retain their information on that portal?
If you're asking, could they go to a health plan and be able to receive the claims information that they encountered while at that health plan, the answer would be yes. They could.
So if you leave, I mean, if you leave most organizations, you know, they shut you down. You don't have access, your password and your username don't work anymore, but that's not the case for health information.
Yeah, so I want to try to, I know this is a little bit of a nuanced point, but it's an important one.
Okay.
Our use case within Karen is, and I know this is jumping ahead on the slides, is specifically focused on individual access of claims data for the health plan you are currently involved in, okay? There, again, there is another use case out there that says if in fact I want to look back on multiple health plans historically on how to access my data, that use case has actually been worked on in DaVinci. And so it's a little bit of a different workflow because you actually have to do member attribution across plans right now, and they're still working through ways that they would do that. I know that's a nuanced point, but hopefully it's helpful.
Yeah, it is helpful. Thank you.
Okay.
Anybody else before we move on? Okay, great.
There was a chat question, so I'll take that as well. Is there anything in the rule that will allow the member or patient to save their health history on a personal storage medium? The answer is yeah. Well, there's nothing in the rule necessarily that talks about that, but these apps that are going to aggregate the individual's data will have the capability to, and do have the capability today to aggregate multiple years of claims history for the individual member themselves. So that is a capability that's actually going to be, that is provided today and will be provided, I think it sounds like from talking to them in the future, where they can do that. I think that's the core use case that most of these apps are going in, is that they will be able to aggregate multiple provider and multiple sets of provider data and multiple sets of claims data. The goal is to make that magically digestible to the member, and that's where the value lies going forward. We'll go to the next slide here. Oh, we've got
actually you have another question.
Great.
They're coming at you from Crystal, who asks, will one user be able to see family members in their login?
So the user, so the business requirements associated with what the user will see will still be maintained and controlled by the individual health plan. Those business requirements differ from portal to portal. And so depending on what those business requirements, they don't change at all. The only that the the way the Smart on Fire process works is that you will supply a member username and password. And through that process, you're going to go through a flow that outlines, again, I think if you're a subscriber, if you're a member, et cetera. But those business requirements are unique to the plan, and they've thought through these items about, you know, giving subscriber access to individual members versus all of that. None of that changes. It's still going to be maintained and controlled by the plan, at least from a business requirements perspective. And I know they've done a lot of thinking on ensuring that they're only delivering the data to the individuals who are authorized to see that data, is my understanding. So. All right, next slide. There are some technical questions, obviously, and these are just some around that. But, you know, do plans have the technical ability to provide the required information? What's the level of effort to build this new infrastructure? So, Dave, this kind of goes back to your point, which is, you know, health plans have an X12 infrastructure today. They don't have a FHIR infrastructure. I'm speaking very broadly. And so they're going to need to support and sustain two different technical infrastructures for the foreseeable future. You know, in an ideal world, it would be great if HIPAA could say you could use either X12 or FHIR for both B2B and B2C transactions. That was a personal, you know, editorial piece of this. We'll wait to see whether that ever happens or not. But I think that, and I only say that because nearly all the plans we have spoken to are very excited about FHIR AP and the APIs and the associations therein, not only for B2C transactions, but also for B2B. And so I think there's a lot of momentum around that. But I want to be very clear about something. We are in no ways trying to usurp or replace X12. We're just providing another way in which this data can actually be exchanged, and you know, doing it in a way that allows for consumers to gain access. Excuse me. So there's look back periods. We talked about the 5-year look back. I won't touch on that again. And then obviously the aggressive timelines. I will say for those health plans that have not started yet, this is not a years-long effort to do this, at least from the plans that we have spoken to. You can actually measure progress in days, weeks, and months rather than years. And many of these plans, even some of the largest in the country, have been able to do this fairly rapidly. In fact, we even tested this on the hospital side to see how quickly they could stand up these API servers. And when in a dedicated effort, they were able to do this actually fairly fast in terms of healthcare speak. And so, but again, your mileage may vary. Trying to reduce the burden as much as possible. I think the idea here is there's a lot of folks out there that can help. Obviously, Julie's group and others, there's a lot of them that can really help make this more streamlined. We'll go to the next slide. There's another rule, the ONC rule, 21st Century Cures Act, that outlines a set of information blocking provisions on what is not considered information blocking and that would be prohibited by cures. And again, I won't go into all of these in detail, but there will be additional detail in the ONC rule, and there is additional detail in the proposed ONC rule about what this looks like. I will say, and I think this is important to reiterate, and this has been said publicly multiple times by administration officials, which are both the ONC rule and the CMS rule are meant to be companion rules. Now, the level of detail associated with what that looks like, we'll need to see in the final rules once they come out. But there is a far more technical detail in the ONC rule than there is in the CMS rule. And for those who have read both of the rules, you'll see that they reference one another. So I guess what we have been saying pretty firmly to folks around in the health IT industry is, you know, hey, if you're a health plan, don't ignore the ONC rule. You should read through the ONC rule and see what things you can learn from that and what things that could be valuable on the health plan side and the CMS side to be able to implement. For example, the ONC rule goes into significant detail about what's called refresh tokens and access tokens and other provisions associated with that. These are things that CMS rule doesn't even talk about, but that are important. And it goes into OpenID Connect and OAuth 2.0 and other things. These are things that are not mentioned in the CMS rule, but these are best practices from a technology perspective that are important to be able to implement. So I think the advice here would be, if you're a health plan, don't ignore the ONC rule just because you know that they don't necessarily regulate the plan space. Look at it for you know, understanding best practices for how to be able to exchange data with apps. We'll go to the next slide. More information. Let's keep going. I know we're going to run out a little bit of time. Next slide. So there is a set, there's a data set called the US CDI, which is going to draft version 1, which is being proposed in the ONC rule as being the foundational set of data that will be provided on the provider side to individual consumers through a third-party app. these are those data classes that they're asking for. I think the key thing in this is there is this thing called clinical notes, which you'll hear many app vendors, but you'll also hear many patients say, it would be fabulous if I could actually see my clinical notes. And the open notes movement has been around for quite some time. They've done a fabulous job in promoting the value of patients actually having having the notes that the physician wrote about them. And this is memorializing that. And there is work being done in other fire accelerator projects called Argonaut, which are going to standardize those clinical notes into a core set of fire APIs for the EHR vendors to implement. And so we're excited to see how that moves forward. Next slide. This is new. Well, this is somewhat new and maybe news to this group. CMS recently proposed earlier this month some policy and technical changes for plan years 2021 and 2022. And as part of that, they were proposing what they call a real-time benefit tool to allow enrollees to view a plan-defined subset of the information, including in the prescriber real-time benefit tool system, which includes accurate, timely, and clinical appropriate patient-specific real-time formulary benefit information, cost, formulary, utilization management. And plans would be permitted to use existing secure patient portals to fulfill this requirement, to develop a new portal or use a computer application. And that obviously means an API to make sure this happens. This is important because we've done some work in the Caring Alliance on what we call real-time pharmacy benefit check and developing a FHIR API for the plan community to use. It has been validated. It is through HL7. We're reconciling the comments now, but it did pass first ballot. It's available for anybody to use today. And so again, depending on whether this language goes final in the manner that it's currently being proposed, plans can proactively, whether it goes final or not, be able to use our API that we've developed to be compliant with this rule. The API provides out-of-pocket costs, formulary alternatives, therapeutic alternatives, and even cash price to the individual consumer. So it does provide a lot more transparency. It helps on a lot of other policy angles as well. There's policy around what's called providing consumers access to that data at the point of prescribing. It removes there's a law in place that removes the gag clause where you can see whether the formulary price or the cash price is cheaper. This is a way to kind of operationalize that legislation that was passed last year. So look at that. Great information there and hopefully helpful tools for the industry to use going forward. Next slide. Thank you, Seraphine, on the published version of USCDI there for folks to be able to access that for more information. All right, so what are we doing to advance the technical standards? Historically speaking, and I'm going to grossly oversimplify this as well, when standards were developed, they typically started in that upper right-hand quadrant. Folks would get together in these standards making bodies like HL7 and SNOMED and others to develop the standards. They would develop implementation guides, and then they would go to the implementers, the private industry, and say, we should do this at scale. We should implement these standards. These are super important. And unless the government kind of got behind it, it was hard to be able to get some adoption across there. Although there was that flow still works today. It's still being implemented today, but it often takes a long time for that to happen, in somewhat years to make that really implemented at scale. What we've tried to do in working in conjunction with HL7 is hopefully have the private industry dedicate more resources to expediting this process. And so what we've done is started in that bottom left-hand quadrant and said, we're a set of implementers, the providers, the plans, the apps, and others who want to develop standards. We want to work with the standards making bodies in the upper right-hand corner to develop these implementation guides so that we could then put them in production and test them. So rather than kind of a years-based effort, we're actually looking at more of a 6 to 9 month sprint to get these done. And there's groups that it sounds like you guys have heard of, Argonaut and Karen and Da Vinci and M-Code that's working on cancer data, and Passio that's working on long-term care information, and Project Gravity, it's work on social determinants of health. These groups, they're trying to really accelerate the standards at scale. And so we think this is a really good model for private industry to work with the standards making bodies and regulators and others to try to expedite these standards in a consensus driven way. And we're working through that together and excited to be one of those accelerators making that happen. Next slide. Well, we can have all the APIs in the world, but if we can't identify unique individuals across systems, then it's going to be really hard for us to implement this. And so one of the ways we believe that this can occur is through what we call digital identity, specifically the ability for an individual consumer to be able to have their own mobile-based, consumer-focused, consumer-owned digital credential on their phone, and that digital credential that's been identity proofed could be used across multiple systems to aggregate their API information to an app of their choice. This is already happening in the private sector and with government. So many of you may have gotten a Real ID card. There is a national standard now, an ISO standard that actually talks about mobile driver's licenses and what needs to be in place to put that on your phone. You could actually see an opportunity where these mobile driver's licenses, these credentials, these digital credentials, could be used to then go forward and log into multiple portals to then aggregate the data. So in other words, Paul Trombino here doesn't need to be validate their identity on multiple different portals, but they can actually say, I'm going to just use my driver's license, my mobile driver's license, to be able to then take that information and then log into multiple portals using that single identity rather than multiple across things. And this doesn't have to be unique to government issued identities. If you don't have any government issued identity at all, which many don't, even for the most vulnerable, they can get identity proof remotely using these NIST standards that exist to make that happen at scale. I think someone's got a question here.
Well, I don't know if I'm the someone. This is Adam. This is a naive question. What if I got Paul Trombino's? What if Paul Trombino left his phone sitting in the Starbucks and I picked it up? What's this? What are the security issues and how did they get dealt with? Yeah.
So the answer to your question is Paul Trombino would actually physically have to have his phone in order for, and it would need to actually be linked, for example, to his biometric on his finger to actually use that. So, I can go into more detail about this, but in order for this to work at scale, it needs to be NIST credential, so NIST IAL2 or AAL2 or higher credential to make this happen. And you would use an ability to, a combination of those factors would then authenticate you into the actual application.
So the risks are pretty low. I take it.
What's that?
So I'm asking. So the risks are fairly low. I think it's not a high-end kind of tech security question, but I think we all lay people wonder. Is somebody going to hack into this? Is somebody going to take it? If you watch too much NCIS on TV, you probably worry about someone getting your finger. But I won't worry about that. But those are the kinds of security issues that I assume are routinely dealt with, and people's concerns are inflated.
Yeah, let's go to the next slide. I think the next slide answers your question, Adam.
Great.
So there are identity proofing guidelines out there. It's the NIST standard. It's called 800-63-3. The TEFCA actually points to these. IAL2 and AAL2 or higher. Would encourage you to look at them. Let's go to the next slide. I think the next one's on AAL2. Yeah, it is. And again, you guys can look at this later. Next slide. Okay, here's the one that answers your question, Adam. There is an open standard out there available today called FIDO2. and the FIDO Alliance, you can look this up. And what this open standard does is it actually solves the problem of usernames and passwords. So today, for example, you know, Adam, if someone actually has your username and password, you don't have to be present. They just take that information. They can log into any site that accepts the combination of the username and password, that two-factor authentication. What FIDO does is it does something a little bit different. It basically says you need to register. And with user approval, what happens is they create a key. It's a public-private sector key, or a public-private key, which basically says, I'm going to take the fingerprint, your individual biometric on your finger, and a cryptographic key in your phone that's actually built into the hardware of your phone. It's not on any cloud device or any application per se. The combination of those two things will be the two factors that actually log you into a system. And what's unique about that is that it eliminates the need for usernames and passwords. Usernames and passwords were the way in which applications today use two-factor authentication to actually log you in securely. What this is doing is it's eliminating that and saying, now if I just have your finger, almost like Touch ID, for example, your fingerprint, and the cryptographic key built into the hardware of your phone, you now have to have your phone and have to have your finger to then log into these sites. Yes, it's not foolproof, understood, but it is certainly much better than we have today. And I will say that every Android 7 device or higher as of last September actually has this built into their operating system. Apple, this is public information on their website, just recently joined the FIDO Alliance as well. So you can see a world that says that every Android and iOS device in the world, eventually, and Microsoft's going to build this into 700 million devices. So you can see a world that you say, hey, you now can actually use this going forward. I will say, as we talk to the security folks, Adam, from NIST and some of the brightest minds in the country on this, they'll tell us that the username and password protocol is basically your username and password is already on the dark web for almost every site you can imagine. I know that scares people a lot, but they have known that for quite some time. And what they're trying to do and what this alliance has done with these organizations is to say, how can we actually eliminate the need for a username and password? And FIDO is one way to make that happen. And it will become ubiquitous on all the devices going forward to really try to lock that down to the individual human person and their individual device. Does that help, Adam? Your question?
I was unmuted. Yeah, it helps a lot. I think this is a fascinating, very, very consumer-centric part of all these processes. I would say, you know, it's probably the principal, if not, it's certainly one of the principal concerns that any consumer patient has.
Great. All right, we'll go to the next slide. All right, so what are we working on? And, you know, how can you get involved? All of the stuff that we do is actually on the HL7 site, hl7.org/Karen. You can actually link to it through that site, or you can also see, I should say, and you can also see the information we're doing on the KarenAlliance.com website. But we've got individual work groups that are doing a bunch of stuff around these topics. We have one called the Code of Conduct and Trust Framework work group that is developing that overall trust framework that I mentioned before. There's some information there that links to our site where you can see some of the work that we've done already on this front. The second work group that we've developed is what we're calling the Consumer Directed Payer Data Exchange, which is what's Blue Button. As I mentioned, that's been approved in the first ballot last month. We're reconciling those comments now. You can see the implementation guide there online, and there's a Zulip chat through HL7. Anybody can participate, weigh in, comments to make that happen. We're reconciling those comments now. We'd love for the broader community to be part of that in any way, shape, or form you'd like. But that implementation guide is something that health plans can and state Medicaid agencies can pick up and implement immediately. The good news is that everyone doesn't have to create their own, which in the proposed rule, that was the assumption. You can just take this and off the shelf be able to implement it at scale. And we're excited to be able to see some of the first pilots come up in 2020 to see how we can continue to improve that. The third work group, as I mentioned, with that new recently proposed regulation, helps to be able to provide real-time pharmacy benefit check information to the consumer. As I mentioned, that's also been approved on the first ballot last month. We're reconciling those comments, and you can see the links there, as well as the Zulip chat if you'd like to get involved in that conversation. And then the final aspect is digital identity and consent. We're working with ONC's FAST project as well on what this looks like, kind of at scale, and how we can work together as an industry to help make this happen. They have other patient identity use cases out there. They have 3 of them. We have a link on our website to it. The FAST team also has a link to the 3 different options that are being equally promoted within the ONC's team as to opportunities for doing patient matching and identity. Carmen's on the phone if we've got some questions about that. But we within Karen are looking at how would we develop a framework for federating a single person-centric identity-proof digital credential across providers and plans based on consumer consent. So this is, if I went out and got my digital credential, which there's a number of private sector vendors that are going to do this and that are doing it today, from what's called a credentialing service provider, if I was to be able to use that credential to log in to multiple portals, plans and provider portals, what are the set of overarching federation principles for how I would actually make that happen at scale? That's what we're trying to identify within the Karen Alliance this year, is what those overriding set of principles actually are for federating that trusted digital credential. That's the key. That's the key piece that we're trying to solve for. Because if we can do that and get some agreement to what that looks like, then, Adam, you can take the Adam Pertman digital credential and use it across multiple different portals to access your data, rather than trying to get identity proofed at every single portal that you go to.
Sounds good to me.
Good. I'm glad.
Yeah. I think we're all tired of this.
Yeah. We want to increase the security, decrease the friction, right? That's absolutely true. Let's go to the next slide. I think this is the last one, and then happy to chat. So still a lot of work to do. On the policy side, we mentioned the Karen Code of Conduct. We will be the first to admit that is not a perfect document. But it is a document that the industry appears to be rallying around. So we would hate to have other people create their own. We would rather have people provide their input to this one. And at the end of the day, we can call it whatever we want. But if we have a single code of conduct, whether we call it the ONC's code of conduct, the Karen code of conduct, the Dave Walsh code of conduct, right? Anything that we want to call it, it's okay. But if that's a single agreed upon set of best practices and principles, that's the only way that can be enforceable at scale in healthcare by the FTC. So that's the key thing, is let's agree on one. We want absolutely the public's opinions and comments around what we can do to improve that without question. On the content side, as I mentioned, there's a bunch of other different FHIR accelerators that are out there that are going to standardize all of this data into FHIR APIs. And we are looking at ways in which we can make sure that each of these individual accelerators are staying in their individual lanes. So we're being additive to each other rather than duplicative. We have a regular meeting to make sure that happens. On the trust side, as I mentioned, digital credentials, there's this NIST standard out there. We already have the open standard available. There's a whole bunch of OpenID, OAuth, FIDO2 available to folks to make that happen. We just need to agree on the federation principles for how we're going to make that happen and some of the technology around that. And again, Direct Trust has already done a bunch of work on this thing. We're excited to work with them this year on how we can work together going forward. On the registration side, there needs to be a way in which these apps are registered. One of the challenges that they have right now is that they're knocking on every provider's door in the country, or many of them, saying, please give me access to the data. It's actually required via 21st Century Cures. I need access to this data. And then they say, what's a FHIR API? And maybe here's my CIO. And you know, you may get permission, you may not. And isn't this a HIPAA violation? There's all these questions. What we're trying to do is figure out a central place that these apps can register, similar to actually what Epic's doing. All of our app vendors, and we believe that Epic's doing it the right way in having a centralized place for the apps to register and then allowing full, complete access to their individual FHIR endpoints by any app that they'd like to. So, and then, you know, we want to be able to measure and this, you know, the connectivity going forward as well to make that happen. There is a question here, which is great. Assuming there's a national certification process would identify the physician associated with the provision of qualified primary health care, is there a means to establish the structure of medical records attached to this level of health care? So I think this is, and Paul, feel free to chime in if, you know, if I'm not understanding your question correctly, but this feels like the provider directory issue a little bit. How do you ensure that the provider who is, that the consumer who's actually trying to get access to the data from an individual provider gets access from their right provider that's been assigned to them? Am I misunderstanding your question there? Or I don't know if Paul's on mute or if he can speak.
You know, our nation's healthcare, thanks for taking the question. Our nation's healthcare, as opposed to most of the other OECD nations, does not have a means to assure that qualified primary healthcare is equitably available to every citizen. And we don't have a means to organize that by community, let alone within individual states. So assuming that we might think about that in the future, it seems to me that this would be associated with some sort of means to certify enhanced primary health care, shall we say, maybe an extension of the medical home concept.
Okay. Got it. Got it.
And,
Paul, you go ahead and finish your thought. I'm sorry.
Well, I just think that within the structure of how information is accessed, that the primacy of access to the data regarding this process of medical care will have greater level of immediacy in terms of the day-to-day process of healthcare, particularly in emergency situations. So anyway, that's the basis for the idea.
Well, Paul, you're bringing up a super important point, and it's more a point about access to primary care in this country, which is a very, very important point. It is not necessarily something that we are tackling within the Alliance itself and the work that we're doing, but certainly you could see a model that says, you know, if an individual patient could be able to access a longitudinal history of both their claims and clinical data for the last 10 years on an app of their choice and make that portable, then the opportunities that would hopefully be uncovered as a result for them to go get primary care from whether that's from you know, from a qualified health center, or whether that's from an urgent care clinic, or whether that's from, you know, wherever they need to see that, they will then be able to have that information in a portable way and be able to share that with their physician. You can see that world come into play. And so I think from that perspective, both the physician and the patient will be more informed. Whether that actually solves the access issue, though, that's for others to, I think, weigh in on.
I have a consumer question. It's a you can lead a horse to water question. There's a technical component, obviously, and a process policy component to all of this, or components to all of this. It's also a consumer behavior model, right? I mean, you need consumers to actually utilize this thing. once you develop the capability for them to do so, right? Is there an element of your work or anybody's work that is doing the market research, the behavioral research, whatever the work that is required to see how do you get the consumers to use the wonderful things that you and I come up with?
Not enough, Adam, by any stretch. There needs to be more. Our hope is that, you know, we can be able to publicize this as much as we possibly can. There's a number of patient advocates right now that are aware of what's happening. Some may have seen a few weeks ago, there was a letter that was drafted by over 200 patient advocates. By the way, this is our HIM schedule. If you want to come, I don't know why you would, but want to come hear me speak more with others that were doing that, you know, feel free to come. We have an open house at HIMSS available to anybody, by the way, if you just want to come talk, and so you can get all that information there. But Adam, to answer your question, the word is getting out. People are starting to understand that a little bit more. It's not as ubiquitous as we would like, but you know, we need to make sure that we listen to the voice of the patient when we do this work. And right now, the voice of the patient is saying, look, we want access to our own data, and we need access to it across these systems. And so what can we do to actually make that happen at scale? And we're trying to make sure we fulfill that commitment.
I guess what I wonder, and this may be out of the scope of your work, but I just wonder, with all of these patient-centered or person-centered systems that are being developed, why isn't the patient component, you know, when I see a chart of the activities, why, and this is not accusatory, I think this is ubiquitously true, why isn't that patient piece, the socialization of it, the reacculturation of people, why isn't that more integral to the work? Because in fact, a given element of any of it could require some interaction or re-education of patients in order to be successful. And so, you know, just having the technical capabilities might not be sufficient. They might be great, and they don't conform to how people think or how people act in a given situation. Are other people doing those? I know you said not enough, but how much is that on the radar of ONC or anybody else who's sort of looking at the very big picture?
Well, I don't want to talk for ONC. I know ONC's done a lot of work to listen to the patient. A lot of that stuff's on their website. I will say that we have quarterly meetings, in-person quarterly meetings, Adam, and the start of every quarterly meeting starts with the patient perspective. We have patient advocates stand up and tell us how difficult it is to access the records and what they want out of the system. We are reaching out aggressively this year as well, and any patient advocate, consumer, caregiver advocate, etc., that want to join, all of them can join and make their voice heard here. So I would say, Adam, that it's a work in progress. We have tried to, although we're not a patient advocacy organization, we do our utmost to advocate on behalf of the patient themselves. By listening to them, by helping to understand what their needs are, and working with them collaboratively going forward.
So Ryan, this is Dave. If I can ask you a quick question. This group is certainly focused on healthcare, but we are equally as focused on human services, housing, justice, a whole bunch of other things that aren't being addressed right now by FHIR. And yet, as a technical person, I look at it, and when you talk about things like authentication using FIDO, it's the same thing. So there are certainly parts that can be leveraged on the human services side that are being really investigated in the healthcare/FHIR side. Another example I'll give you is in the world of HIPAA transactions, CAQH came out with the core operating rules. So they came out with a set of operating rules on how HIPAA transactions are conducted. One of those was the core connectivity rule, how you get information from point A to point B. There's a lot of work going on right now in the fire domain that could be repurposed for the human services domain, even if the payload is not a fire resource. So it could be that the payload piece of it is a NEAM resource, but everything else that we're doing is almost identical. So are you seeing much of an effort to repurpose, reuse, leverage things that are going on with fire to other domains like human services?
Oh, absolutely. Yeah. And we didn't have a chance to talk about it today, Dave, but I guess let me just raise it up a notch because you got pretty technical there, but this is the Let's Get Technical group. So maybe we need to go there. I will say that keep in mind that state Medicaid agencies, based on the proposed rule, will need to implement a fire technical infrastructure, right? So that's point number one. That's a big step, right? That hasn't been happening across the country. Once they do that, they develop their API gateway to make that happen, all kinds of fun things start to happen, right? One is patients get access to the Medicaid fee-for-service claims directly from the Medicaid agency. But in addition to that, they can start to be able to exchange APIs or other things using that new technical infrastructure, even within the state itself, right, to make that happen. Now, to your point about human services, same thing. I mean, there's always been this battle between MMIS and eligibility enrollment, and whether you develop a similar infrastructure, you know this, Dave, across both areas. The hope is we can get there. But when we talk about social determinants, all the work that Gravity's doing for their social determinants, you could envision a world that says, look, I need to get a fire API from the community-based organization or the proprietary, vendor that actually manages this information into the state health and human services side, right? Whether you use fire or NEAM or whatever you decide to do, there's a connection point there to say the state's got a ton of resources for you, SNAP, TANF, CHIP, all the stuff that you've got up there. How do we actually make this happen at scale? Those are some of the exciting discussions we're having. And how do you get a single interface built into these community-based organizations so you can do closed loop referrals and all the fun stuff you need to do there? Those are the discussions we're starting to have in other forums about what that actually looks like at scale. Because let me just do one thing on social determinants, and this is super important. Many organizations are stepping up funding social determinant like pilots because I think longitudinally everyone says it's the right thing to do. The problem is that many of those investments that are occurring are investments that are occurring by the healthcare industry, and
Okay.
continue to make those investments, they're going to have to see a return on their investment, right? Because they're not going to continue to dump money into something that they can't see that return. And as those who've been working on this, Adam, your group and others have been working on this for a long time, those returns could be measured in years, maybe even decades, right? So we have to figure out a way using the data, and that's the key phrase, using the data, to be able to assess what that return looks like so those investments can continue to be made. And what our hope is, again, in other forums that we're working on this, is to figure out a way to be able to standardize that information so that we know that the, whatever it is, 100 people that we referred out of the ED to go into a homeless shelter because they were spending way too much time in the ED is going to save the hospital hundreds of thousands of dollars, right? You can make those value judgments and those quantitative judgments based on the data itself and how that works. And we also have to agree on what the open standards are, because we do not want to be in a situation where we have ginormous legacy vendors in place that are hoarding data on the social determinant side, like we got into the EHR side. We want to make that open. We want to make that available to everyone, especially on the SDOH side, and protect that information regardless of where it sits.
And there's an education process in this too, right? Because those healthcare funders need to see that the return on investment is not a narrow one, right? It needs to expand into other domains, or they won't see the return because it isn't that direct.
Right, absolutely. This return as well is a societal return, right? It's not just to the
Right.
health industry, it's the society. So how do you measure that? How do you track it? There's a lot of smart people doing a lot of great work on that front, but how do we agree as an industry what those metrics actually look like? But do we have the data to make that judgment? So
one,
Ryan, this is a vendor. Just on the return thing, you said there's a lot of work that's been done. Is there any published position paper as to what's the period of return? What kind of sort of data points are available for people to really objectify sort of the value behind all of these investments? Any threads that are working on it, or any papers that have been published that is more than just we all believe that there is value in all of this, but is there any objectification done in any of these threads, if you will?
yeah, others are probably smarter than me on this topic, but I know Siren's done some work on this. There's out of ECSF and the area that's up in San Francisco, there's been work done as well by the Commonwealth Fund too. They've got actually an ROI calculator on their website. There has been some work that's been out there. Arvinder, I don't have it off the top of my head other than that, but there's some, there is a group that we help lead. Again, I didn't have a chance. I'll put it in the chat though, that actually has done some additional work too, that maybe have some, you may be able to look at as well for some more information. I'll put it out.
Got it. Thank you.
Great, thank you, Arvinder. There's a question from Greg Bloom in the chat. Greg, can you unmute and just ask it, or do you want us to read it?
I think it was the same question that was just asked. I was really interested to hear other examples of people who are doing the work of assessing the impacts. I do want to mention from my conversations across the board, it seems like there's real tension between these drives to demonstrate ROI and the broader framework of health equity that is coming into place in these fields, where, you know, it's pretty clear that some objectives of demonstrating return on investment are not necessarily aligned with individuals and communities' interests. And so I think there is a question of how to align incentives for demonstrating cost savings with the priorities of achieving health equity.
Yeah, and another subject that deserves its own webinar.
It's a great question. It's a really great question.
so Ryan, one other question, and I'm just losing the name of it right now, but there was an initiative out of CMS some years ago that allowed the results of CMS funding to build technologies, for those technologies to be reused in the human services space, for example. I forget the exact role. I think it may have expired in 2018. Do you recall what I'm talking about?
I don't.
Okay. If anybody recalls that specific initiative, the question is, can healthcare funding be applied to human services? And there was a period of time when CMS said that that was okay, but it may have expired by now. And I was just wondering.
Oh, that was for the ACA, I think.
Anybody on the call know the answer? That's fine.
Okay, I'll figure it out. Thanks, Ryan.
All right, we have time for one more question if someone has it. Otherwise, we're going to move into just previewing what is coming up. Anybody? All right. So let's move ahead with the slides. But first, Ryan, thank you. That was terrific. On behalf of all of us, yeah, thumbs up all the way. Thank you. And good luck with the work. We want to stay in touch on it, and we want to figure out, you know, how can we help each other. I think that's part of what all of us are here to figure out.
Absolutely.
Okay, next slide. So we're going to talk about a couple of upcoming webinars and an upcoming event. Please note that this particular webinar is not not at our regular Friday time. This is a big, broad look at NEAM. It's the webinar itself will be in 2 parts. Those of you who want a broad overview of NEAM in and of itself and its efforts to set up a health domain, the first hour is for you, is probably for nearly all of us. And then in the second hour, I'm not going to, but the presenters are going to take a look at this health domain for NEAM, what it's going to look like, what the goals of it are, and I think how we can participate. Nick is going to participate in that effort, I'm happy to say. And I invite you all to join us. It's from 12 to 2. Is that next? If the 26th is next, I want to say Wednesday. Do I have that correct? Anyone with a calendar?
Yes, it's Wednesday, Adam.
Thank you very much. And we will send out a notice as well. Please know that in addition to the webinars that I'm going to describe, this one and one more, there are, if you want a list of the webinars that are coming up on these Friday calls, that is on the NIC site, and we invite you to take a look, and please do join us. The next slide. Oh, okay, so I'm going to, before I get to the next week's webinar, I'm going to ask Kate Ryan to jump in and tell us a little bit about this Health Innovation Day.
Thank you, Adam. Okay, so hello everyone, Kate Ryan from Iris Health Solutions. Just real quick, ACT-IAC, so the American Council for Technology and Industry Advisory Council, they're holding a Health Innovation Day. And I'm not sure how many of you are familiar with the interoperability showcase that takes place at the HIMSS convention each year, but they're going to do a smaller version of that. It will be federally focused as well as focused on healthcare, and they'll be putting together vignettes and piloted presentations. So if anyone is interested in perhaps demonstrating, being a demonstrator there, please let myself or Carol Miller know. She'll be organizing the event. Or if you're just interested in participating and attending and listening to some of the different speakers, there's keynotes from HHS, VA, and DHA there. And they're slowly putting together that new demonstration piece. It will be the first time that they do an interoperability showcase type of a session. So again, if you are interested, if you'd like some more information, there is down here at the bottom corner, the actiac.org, the link to their website. And I've also included Carol's information if you're interested.
Great, thank you for that. And I think that Dave, Daniel, you and I are going to take a look at this too, right?
Yes.
Yeah, that's great. And the next slide. This is next week's webinar, next Friday. There are pictures of, there's my picture, my goodness. So some of you know that my alter ego, my secret life, I'm a child welfare subject matter expert. You can read the bio. The main presenter next week will be Daniel Hempel, who is also, like me, a former journalist who moved into that field, and he has done some terrific work, and he's now publisher of the Chronicle of Social Change. We did one child welfare related webinar some weeks ago. It was very well attended. It was really interesting, and I do have a biased perspective on that, but I think the level of attendance and response attests to that. And we would love to, for all of you to join us, spread the word. It's a different kind of webinar, but we will bring it into our world for sure. And this is obviously a subject that affects a lot of children and families across our country as we think about social mobility and economic and racial equity. These are big issues in this world, and I think well worth exploring. So that'll be the next presentation next week with Daniel taking the lead, and I will be chiming in as well. And do we have one more slide, Will? There? And that's right on time. Please join us. If you haven't signed up, please do. If you want to sponsor our work, there are opportunities to do that. And we invite you just to keep coming back for these conversations and everything that grows out of them. And lots, in fact, is growing out of them. So thank you all very, very much, and have a wonderful weekend.
Thanks, Adam, and thank you, Ryan. It was really